You're about to learn something that could save your grandchild's life. I'm going to reveal the sleeping positions that doctors from Johns Hopkins, Mayo Clinic, and the American Academy of Pediatrics are warning every parent and grandparent about. Some of these might shock you because they're positions you used with your own children years ago. But here's what's changed. We now have decades of research showing exactly why these positions are deadly. After 40 years in psychology working with families, I've made it my mission to bridge the gap between old practices and life-saving modern evidence. Today, I'm going to explain exactly what happens inside your grandchild's body when they're placed in these dangerous positions. The first dangerous position is stomach sleeping. When you place a baby on their stomach to sleep, you're creating a perfect storm of physiological dangers. The Chicago Infant Mortality Study analyzed 260 sudden infant death syndrome cases and found that babies placed on their stomachs had more than double the risk compared to other positions. Here's why. When an infant lies face down, their airway can become compressed against the mattress. Unlike adults who can quickly turn their heads, babies under 4 months have weak neck muscles. Their nervous system is still developing the reflexes needed to reposition themselves when breathing becomes difficult. This creates what researchers call the triple risk model for sudden infant death syndrome. Inside the baby's body, something even more dangerous is happening. When their face presses into the mattress or bedding, they begin rebreathing their own exhaled air. Each breath they take contains less oxygen and more carbon dioxide than the last. Normally, when carbon dioxide levels rise in your blood, your brain triggers an immediate response to wake you up and adjust your position. But in babies, especially those placed in unfamiliar stomach positions, this arousal mechanism doesn't work properly. Studies from Washington University showed that babies unaccustomed to stomach sleeping face 7 to 8 times higher risk when suddenly placed in this position. Why? Because they haven't developed the adaptive behaviors like turning their heads to clear their airways. Their brain literally doesn't know how to respond to the danger. The overheating factor compounds everything. Babies generate body heat quickly, and when they're on their stomachs, up to 25% of that heat normally dissipates through their heads. But stomach sleeping, especially with any bedding around their face, traps this heat. Brain imaging studies show that elevated brain temperature impairs the autonomic nervous system, the very system responsible for breathing regulation during sleep. Now here's where it gets even more critical. If your grandchild has recently been ill with any respiratory infection, stomach sleeping increases the risk over tenfold. The illness already compromises their breathing efficiency, and the stomach position creates additional obstruction. This is why the American Academy of Pediatrics issued their strongest recommendation. Always place babies on their backs for every sleep, every time, until they're at least 1 year old. I know what some of you are thinking. But my babies all slept on their stomachs, and they were fine. I hear this constantly. The issue isn't that every baby on their stomach will die. The issue is that we now understand the specific mechanisms that cause thousands of preventable deaths. The Back to Sleep campaign, launched in the 1990s, reduced sudden infant death syndrome rates by over 50% simply by changing this one practice. For toddlers over 1 year old, the acute risk of sudden infant death syndrome drops dramatically because their neurological and muscular systems have matured. They can reposition themselves effectively. However, if your toddler is sleeping on soft bedding or has any medical complexity, stomach sleeping can still pose suffocation risks through facial entrapment or restricted movement. The bottom line, never, under any circumstances, place a baby under 12 months on their stomach to sleep. For toddlers, while the risk is lower, always ensure they're on a firm, flat mattress without soft bedding if they naturally roll to their stomach. And please, share this information with every caregiver in your grandchild's life. The second dangerous sleeping position is on the side. Side sleeping might seem like a safe middle ground between stomach and back, but research reveals it's just as dangerous for infants, perhaps even more so in certain situations. The New Zealand Cot Death Study, which analyzed 485 sudden infant death syndrome cases and 1,800 control infants, found that side sleeping carries an intermediate risk initially. But here's the critical finding. Side sleeping is inherently unstable. Why is side sleeping so unstable? Picture a baby lying on their side. Their body is essentially balanced on a narrow edge. During sleep, muscle tone decreases naturally as the baby cycles through different sleep stages. When this happens, gravity takes over. The baby's body weight shifts, and they roll forward onto their stomach. This is where the danger multiplies exponentially. Studies tracking infant sleep patterns with video monitoring found that babies placed on their sides typically roll to their stomachs within minutes to hours. Once on their stomachs, all the risks I explained earlier activates: airway compression, carbon dioxide rebreathing, overheating, and impaired arousal responses. Inside the baby's cardiovascular system, side sleeping creates additional stress. When lying on one side consistently, blood pooling can occur, causing what's called harlequin color change in about 10% of healthy newborns. While harmless in itself, it indicates how vulnerable infant circulation is to positional changes. More concerning is the effect on the heart and lungs. The lower lung becomes compressed by body weight, reducing oxygen exchange efficiency. For babies with any respiratory vulnerability, even minor, this can tip them into dangerous territory. The neuromuscular development also suffers. Babies who spend extensive time on one side can develop plagiocephaly, a flattening of the skull that affects up to 47% of infants in some studies. Now let me address a dangerous myth that keeps circulating in parenting circles and family traditions. Many people believe side sleeping prevents choking if the baby spits up or vomits. The evidence completely contradicts this. Side and stomach sleeping can actually increase aspiration risk because the baby's position and reduced arousal might prevent them from clearing fluids effectively. This myth has literally cost lives because families chose what they thought was safer and ended up increasing risk. For toddlers between 1 and 8 years old, side sleeping shifts from an acute sudden infant death syndrome risk to a potential contributor to developmental issues. Studies examining gait patterns in toddlers found that children who habitually sleep on one side sometimes develop internal rotation of the legs, leading to an in-toeing gait. You might notice your grandchild's feet turning inward when they walk. Shoe wear studies corroborate this, showing uneven wear patterns correlating with sleep position preferences. Dental health can also be affected. Habitual side sleeping applies uneven pressure on the developing jaw and teeth. This can contribute to malocclusion, misalignment of the bite that might require orthodontic intervention later. Some dentists are now screening for sleep position as part of dental evaluations because the correlation is that strong. Here's my specific advice for your grandchildren. For babies under 12 months, always place them on their backs to sleep. The next dangerous position is inclined sleeping beyond 10 degrees. This position might be the most insidious because it often happens in products specifically marketed for babies. Let me explain why inclined sleeping is so dangerous and why federal agencies have banned entire categories of these products. Between 2005 and 2019, the Consumer Product Safety Commission documented 108 incidents and 73 deaths directly tied to inclined sleepers. These aren't just statistics. Each number represents a family's tragedy. Products like the Fisher-Price Rock and Play, which sold millions of units, were recalled after babies died. Let me explain the exact mechanisms that make inclined sleeping lethal. When you place a baby on a surface tilted more than 10 degrees, gravity becomes your enemy. The baby's body naturally slides downward, even if imperceptibly at first. As their body moves down, their head flexes forward, creating what's called a chin-to-chest position. This posture compresses the airway in the neck. The soft tissues of an infant's throat aren't rigid like in adults. They collapse under pressure. A groundbreaking 2019 biomechanical study at the University of Arkansas for Medical Sciences tested 15 infants on various inclined surfaces. The researchers measured muscle activity, oxygen levels, and positioning using sophisticated monitoring equipment. On 20-degree inclines, they found that abdominal muscle activity increased by 71% when babies were in prone positions. The babies' bodies were working desperately to maintain posture. Here's the critical finding. Despite increased muscle activity up to 200% of normal, the infants still couldn't maintain safe positions. They fatigued quickly, and their oxygen saturation levels dropped twice as frequently compared to flat surfaces. In some cases, babies experienced desaturation events, where blood oxygen levels fell below 90% within minutes. For context, healthy oxygen saturation should be 95 to 100%. The study's conclusion was unequivocal. No inclined products are safe for infant sleep, regardless of marketing claims. Now, let's talk about what happens to the respiratory system during inclined sleeping. When the chin drops to the chest, it kinks the airway like bending a straw. Air can't flow freely. The baby has to work much harder to breathe. This increased work of breathing consumes oxygen and energy. If the baby is in a deep sleep phase when muscle tone is naturally lowest, they might not have enough strength to lift their head and open the airway. Hypoventilation is another danger. This means inadequate ventilation where carbon dioxide builds up in the blood because the baby can't breathe deeply enough to expel it. In severe cases, this leads to hypercapnia, elevated carbon dioxide levels that cause acidosis in the blood. The brain responds by becoming more suppressed, creating a vicious cycle where the drive to breathe diminishes exactly when it needs to increase. Premature babies face exponentially higher risks. Their respiratory control systems are even less mature, their muscles weaker, their airways smaller. Multiple studies have documented that premature infants in inclined positions experience more frequent apnea episodes, pauses in breathing that last 10 seconds or longer, and more severe oxygen desaturation events. Another harmful position is the semi-upright or sitting positions. Let me tell you about a phenomenon called positional asphyxia that most grandparents have never heard of but desperately need to understand. Positional asphyxia occurs when a baby's position causes their airway to become blocked. But unlike choking or obvious suffocation, there's no external object involved. The baby's own body position creates the obstruction. In semi-upright or sitting positions, like in swings, bouncy seats, or car seats used outside vehicles, the baby's head falls forward into that deadly chin-to-chest posture I mentioned earlier. Here's what makes this so insidious. Babies don't struggle or cry out because the airway blockage develops gradually as they fall into deeper sleep and their muscle tone decreases. There's no sudden event to trigger their arousal reflexes. Parents or grandparents in the same room might not notice anything wrong until the baby has already stopped breathing for a dangerous length of time. A comprehensive 10-year review analyzed 11,779 sleep-related infant deaths and found 348 of them, that's 3%, occurred in sitting devices. Of those, 63% were in car seats. But remember, only 10% were during actual car travel. Most happened because the car seat had become a bed at home. Another analysis of 47 deaths in sitting devices found 66% were in car seats, with positional asphyxia identified as the leading cause of death. Let me explain the physiology in detail. When a baby sits upright or semi-upright, their disproportionately large and heavy head, it's about 25% of their body weight compared to 15% in adults, pulls forward due to gravity. Their weak neck muscles, especially in babies under 4 months, can't maintain proper head position during sleep. As the head drops, the jaw presses into the chest. This compresses the soft tissue of the throat and narrows the airway opening. Oxygen saturation studies on infants in car seats have documented desaturation events in both term and premature babies. In one study, researchers monitored oxygen levels continuously in newborns placed in car seats. Even in properly installed seats with babies correctly positioned, they observed drops in oxygen saturation below 95%. Some babies experienced events where oxygen fell below 90%, levels that can cause cellular damage if prolonged. Straps add another layer of danger. The harness systems in these devices are designed to keep babies secure during movement, but they can shift during sleep. A tragic 2019 case involved a newborn who died from positional asphyxia in a car seat at home. Investigation revealed the chest clip had moved upward toward the baby's neck during sleep and, combined with forward head position, created complete airway occlusion. The baby's mother found him unresponsive after a 2-hour nap. So what should you do? Car seats are for car travel, period. If you're traveling and your grandchild falls asleep, have someone sit in the back to monitor head position constantly. If the head slumps forward, gently support it or reposition the baby. As soon as you reach your destination, even if it's just a quick stop, move the baby to a flat, firm surface. The next position is sleeping on a parent's chest. Now we come to a position that many families practice for bonding and breastfeeding, but which carries significant risks that need to be understood. Sleeping on a parent's chest, also called chest sleeping, has been studied extensively with findings that every grandparent needs to know. What makes chest sleeping dangerous? Multiple mechanisms are at work. First, there's the risk of overlay, where a parent who falls into deep sleep rolls or shifts position and inadvertently covers part of the baby's face or body, restricting breathing. A parent might not realize they've moved until it's too late. Second, airway obstruction can occur from the baby's face pressing into the parent's chest. Babies don't have the neck strength or arousal response to effectively reposition themselves if their nose and mouth become blocked against skin, clothing, or blankets. The soft fabric of a shirt or the flesh of a chest can mold around the baby's face, creating an airtight seal that prevents breathing. Third, overheating is a major concern. Babies in close contact with an adult body absorb heat rapidly. Remember, babies lose significant heat through their heads, but when sleeping on a chest, their head is often covered or pressed against warm skin. Studies have linked overheating to sudden infant death syndrome through mechanisms involving impaired autonomic control. Body temperatures in sudden infant death syndrome cases at autopsy sometimes reached 42 degrees Celsius, well above the normal 37 degrees Celsius. The risk factors that amplify these dangers are critical to understand. A landmark study found that bed sharing when a parent has consumed alcohol increases sudden infant death syndrome risk 18 times. If co-sleeping occurs on a sofa or armchair, the most common place for chest sleeping, the risk increases up to 50 times compared to room sharing without bed sharing. Sofas create entrapment hazards where babies can become wedged between cushions and the parent's body. Let me explain what happens at a cellular level during these events. When a baby's airway becomes blocked, carbon dioxide levels rise while oxygen levels fall in the bloodstream. The carotid bodies, sensors in the neck arteries, normally detect this and trigger arousal. But research shows that close body contact can actually suppress these arousal mechanisms. The warmth, the physical contact, and the sound of the parent's heartbeat all promote deeper sleep states in the baby. This deep sleep, while seeming positive, reduces the baby's ability to respond to hypoxia, low oxygen conditions. Why do parents and grandparents practice chest sleeping? Often it starts during breastfeeding. The baby nurses and falls asleep on the mother's chest. The mother, exhausted from nighttime wakings, also falls asleep. Or a grandparent soothing a fussy baby finds the chest position calms them, and both drift off. These scenarios are incredibly common, which is why unplanned co-sleeping appears in 60% of deaths. Culturally, chest sleeping has deep roots. Some research points to evolutionary benefits, where maternal breathing and heartbeat regulate infant breathing patterns. The close contact facilitates breastfeeding, improves maternal sleep by reducing the need to get up repeatedly, and promotes bonding. But let me offer practical guidance. If you need to soothe your grandchild by holding them, stay awake. Set a timer on your phone if you think you might drift off. Once the baby is calmed or fed, place them in their own sleep space. If you're exhausted and worried you might fall asleep, put the baby down first, then rest yourself. A crying baby is unpleasant but safe. Another dangerous position is sleeping with a hyperextended neck with their head arched back. This position often surprises grandparents because it's not something you usually place a baby in intentionally. Instead, it's a position babies assume themselves, and when you see it, it's actually a warning sign of a potentially serious underlying problem. When a baby or toddler sleeps with their neck hyperextended, meaning their head is tilted far back with the chin pointing upward, it typically indicates they're struggling to breathe. The child instinctively arches their neck to open their airway as much as possible. While this might help them breathe in the moment, it signals sleep-disordered breathing or obstructive sleep apnea that needs medical evaluation. Obstructive sleep apnea occurs when the airway becomes partially or completely blocked during sleep, usually due to enlarged tonsils, adenoids, or both. As the child falls asleep, the muscles of the throat and tongue relax naturally. But if the tonsils and adenoids are enlarged, these relaxed muscles allow the tissues to collapse into the airway space. The child's brain detects the reduced airflow and sends signals to breathe harder. This creates negative pressure in the airway, which paradoxically causes even more collapse, like sucking on a straw makes it flatten. The child experiences what's called an apnea, a complete pause in breathing lasting at least 10 seconds, or a hypopnea, a significant reduction in airflow lasting 10 seconds or more. During these events, oxygen saturation in the blood drops. The brain responds with a partial arousal that tenses the muscles, opens the airway briefly, and the child gasps or snorts to get air. Then they fall back into sleep, and the cycle repeats, sometimes dozens or hundreds of times per night. The hyperextended neck position is the body's attempt to maintain the widest possible airway opening. By tilting the head back, the child straightens the pathway from nose and mouth down to the lungs. It's an adaptive mechanism, but it indicates the problem is significant enough to require this compensation. What are the consequences of untreated sleep-disordered breathing? In the short term, the fragmented sleep leads to daytime symptoms that might surprise you. Rather than appearing tired, many children with sleep apnea actually become hyperactive. They might be misdiagnosed with attention deficit hyperactivity disorder. Studies estimate that 25% of children diagnosed with attention deficit hyperactivity disorder actually have underlying sleep-disordered breathing as the cause of their behavior problems. The poor sleep quality affects learning and memory. During deep sleep, the brain consolidates memories and processes information learned during the day. When sleep is constantly interrupted, this consolidation doesn't happen effectively. Children might struggle academically not because they're not smart or paying attention, but because their brain can't properly store and retrieve information due to fragmented sleep. Mood and behavioral issues arise as well. Irritability, mood swings, aggression, and anxiety are all more common in children with sleep-disordered breathing. Cardiovascular strain is another serious concern. Each apnea episode creates a burst of stress hormones as the body responds to low oxygen. Blood pressure spikes during these events. Over time, this can lead to chronic hypertension, even in children. Some children develop pulmonary hypertension, elevated pressure in the lung blood vessels, or structural changes to the heart like ventricular thickening. These are effects we typically associate with adult diseases, but they're appearing in children with untreated sleep apnea. Growth can be affected because growth hormone is primarily secreted during deep sleep. When children don't reach deep sleep stages or those stages are constantly interrupted, growth hormone release decreases. Metabolic complications include insulin resistance and increased risk of obesity. The relationship is bidirectional. Obesity worsens sleep apnea by adding tissue that crowds the airway, and poor sleep affects hormones that regulate appetite and metabolism, promoting weight gain. As a grandparent, if you notice your grandchild sleeping with a hyperextended neck regularly, bring it to the parent's attention and encourage medical evaluation. The next wrong sleeping position for your grandchildren is the extremely curled fetal position. The fetal position, where a child lies on their side with knees drawn toward their chest, is one of the most common sleep positions across all ages. It mimics the position babies held in the womb, and many find it comforting. However, an extreme version of this position, where the child is tightly balled up with knees pressed firmly against the chest and restricted movement, introduces some risks worth understanding. Before I alarm you, let me be clear. The fetal position itself is generally safe for babies and toddlers. The concerns arise specifically with extreme curling and persistent side sleeping that creates instability for infants. For babies under 12 months, the primary risk relates to the side sleeping component of the fetal position. As I explained earlier, side sleeping is unstable. A baby in a curled fetal position is essentially on their side, and during sleep, when muscle tone decreases, they can roll forward onto their stomach. Once prone, all the sudden infant death syndrome risks I've already discussed activate. The extreme curling aspect adds a potential breathing restriction. When the knees are pulled very tightly to the chest, this compresses the abdomen and diaphragm. The diaphragm is the primary muscle of breathing, a dome-shaped sheet that contracts downward to expand the lungs. If the abdomen is compressed by bent legs pressed tightly, the diaphragm can't descend fully. This means each breath brings in less air, leading to shallower breathing and potentially lower oxygen saturation over time. Think about trying to take a deep breath while hunched over versus sitting up straight. The hunched position limits how much your lungs can expand. For babies, whose breathing mechanics are already less efficient than adults, this limitation matters more. Studies examining infant breathing patterns show that positions restricting chest and abdominal expansion can reduce tidal volume, the amount of air moved with each breath, by measurable amounts. For babies with pre-existing respiratory conditions like asthma or bronchiolitis, even minor reductions in breathing efficiency can tip them into distress. Musculoskeletal concerns appear more relevant for toddlers who maintain extreme fetal positions habitually. Prolonged tight curling can cause temporary tension in hip flexor muscles, the muscles at the front of the hips that lift the knees. If these muscles stay contracted for hours every night, they can become tight, leading to reduced hip extension and potential gait changes. You might notice your grandchild has difficulty straightening their legs fully or seems to walk with slightly bent knees. Hip joint health in babies is another consideration. Improper swaddling that forces a tight fetal position with legs pressed together and extended rather than naturally bent can increase the risk of hip dysplasia. This condition involves loosening of the hip joint and damage to the cartilage. It affects up to 1 in 100 infants, and positioning is a modifiable risk factor. For toddlers, habitual extreme curling might contribute to spinal alignment issues, though evidence here is more limited and anecdotal. Some physical therapists report seeing postural imbalances in children who sleep extremely curled. Sleep quality itself can suffer if the position causes discomfort. Children who wake frequently during the night because of cramping or stiffness from extreme curling might experience the sleep fragmentation effects I mentioned earlier, including daytime irritability, attention problems, or behavioral issues. Another dangerous sleeping position is sleeping with head covered or buried. This position ranks among the most dangerous on this list, particularly for babies, because it directly interferes with two critical physiological needs: breathing and temperature regulation. when a baby's head becomes covered by a blanket, hat, or soft bedding, or when they burrow face first into a pillow or mattress surface. They create what researchers call a microenvironment around their face. This pocket of air has very different properties than room air. Each time the baby exhales, they release carbon dioxide-rich air into this space. Each inhalation draws from the same pocket, now containing less oxygen and more carbon dioxide than before. This cycle, called rebreathing, rapidly depletes oxygen while carbon dioxide accumulates to dangerous levels. Research documenting air samples from covered infant faces shows carbon dioxide concentrations can reach 5 to 10%, compared to the normal atmospheric level of 0.04%. At these concentrations, carbon dioxide acts as a respiratory depressant, meaning it actually suppresses the drive to breathe, creating a dangerous feedback loop. The brain's respiratory center becomes less responsive exactly when it needs to signal harder breathing efforts. Simultaneously, oxygen levels in the inspired air drop from the normal 21% to sometimes below 15%. This hypoxic environment means each breath delivers less oxygen to the bloodstream. For a baby whose brain has high oxygen demands for growth and development, even brief periods of reduced oxygen can have consequences. Blood oxygen saturation drops, and if low enough or prolonged, can cause cellular damage. The arousal mechanisms I've mentioned earlier become critically important here. Normally, when carbon dioxide rises or oxygen falls, sensors in the brainstem trigger arousal to wake the person and prompt them to change position or breathe differently. But studies on infants with head covering show this arousal response is impaired. Temperature regulation is the second major mechanism of danger. Infants lose up to 25% of their body heat through their heads because the head is disproportionately large relative to body size and has high blood flow. When you cover a baby's head, you trap this heat. Studies measuring temperature under head coverings show increases of 0.29 degrees Celsius per hour in newborns. This might sound minor, but consider that a baby with a mild fever starting at 38 degrees Celsius could reach 39 or even 40 degrees within a couple of hours if head covering prevents heat dissipation. Hyperthermia, elevated body temperature, is strongly associated with sudden infant death syndrome. Autopsy studies show 19 to 40% of sudden infant death syndrome victims had evidence of overheating, with rectal temperatures sometimes reaching 42 degrees Celsius, well above the normal 37 degrees Celsius. The last sleeping position on this list is bed sharing or co-sleeping. Bed sharing, where the baby or toddler sleeps in the same bed as a parent or other adult, is common worldwide, but carries significant risks that every grandparent needs to understand fully. A 2025 study analyzing 7,600 sudden unexpected infant deaths in the United States between 2011 and 2020 found that nearly 60% occurred in shared sleep spaces. Of those deaths, 75% happened in adult beds. Here's the critical detail that often gets lost in bed-sharing debates. At least 92% of co-sleeping deaths involved hazardous circumstances and 60% were unplanned. What this means is that families didn't plan to bed share, but fell asleep exhausted with their baby in the bed, or they bed shared under circumstances known to increase risk, like after consuming alcohol, on a sofa instead of a bed, or with heavy bedding and pillows around. This distinction matters because it shapes how we discuss and address the risks. Let me walk through the specific mechanisms that make bed sharing dangerous. First is overlay, where an adult rolls over onto the baby during sleep. A parent in deep sleep might shift position and inadvertently cover part of the baby's face, chest, or entire body without immediately realizing it. The adult's weight can restrict the baby's breathing either by pressing on the chest and preventing lung expansion or by covering the nose and mouth. Entrapment is another mechanism. This occurs when the baby becomes wedged between the mattress and the wall, headboard, footboard, bed frame, or another person. In this trapped position, the baby can't move or cry out effectively. Their face might be pressed against a surface that blocks breathing. Studies documenting bed-sharing deaths frequently find babies in these entrapment scenarios. Suffocation from bedding represents a third pathway. Adult beds typically have multiple pillows, thick comforters, sheets, and blankets. If the baby's face becomes covered by any of these items, the rebreathing and overheating problems I explained earlier come into play. Soft pillows in particular pose risk because a baby's face can sink into the pillow, creating an airtight seal around the nose and mouth. Overheating occurs more easily in bed-sharing situations because of close body contact with the adult's warm body plus the bedding materials. Remember, babies need to lose heat through their heads, and bed-sharing environments often result in head covering or close contact that prevents heat dissipation. Research quantifying these risks has produced extensive data. The landmark 2013 individual-level meta-analysis combined 5 major case control studies involving 1,472 sudden infant death syndrome cases and 4,679 control infants. The analysis found that bed sharing increased sudden infant death syndrome risk with an overall adjusted odds ratio of 2.7. For breastfed babies under 3 months with no other hazards, meaning parents who didn't smoke, drink alcohol, or use drugs, the adjusted odds ratio was 5.1. Alcohol and drug consumption before sleep is even more dangerous. Consuming 2 or more units of alcohol increases bed-sharing sudden infant death syndrome risk 89.7-fold, almost 90 times higher. Alcohol impairs parental arousal and responsiveness. A parent who has been drinking might not wake if the baby is in distress, might roll over onto the baby without awareness, or might position the baby unsafely before falling asleep themselves. For grandparents, the key messages are these. Never bed share if you have consumed any alcohol, used medications that cause drowsiness, or are extremely fatigued to the point where your alertness is impaired. If you bring your grandchild into your bed for feeding or comforting, stay awake and return them to their separate sleep space before you sleep. Thank you for watching. If you enjoyed watching this video, click on one of the boxes playing on your screen to watch more similar content.